Alright, this is our follow-up ICM Chest Radiology discussion, and we're going to talk about interpreting the chest x-ray and developing a search pattern, and we're going to review some of our normal anatomy so that we can become accomplished radiologists like our friends here. Okay, so let's move along. Here's my conflict of interest disclosure that I'm the grandson of Dr. Neifer, who came up with Dr. Neifer's lung tonic, developed in Abbeville, South Carolina, and treated people during the flu epidemic in 1918. So I guess if I'm going to talk about pulmonary diseases, I have to disclose my conflict of interest there. And there's Papa Neifer, and there's his name, Neifer, South Carolina. And for interest, there's a x-ray on the wall, and the date was 1903. All right, so interpreting the chest x-ray, we've got to also think about normal anatomy and variation, and that's really hard to come up with how you can understand that right now. You really have to have some experience, and it'll just come with looking at a lot of x-rays over time. But I think the key things to remember is the patient's age and the history will go a long way towards telling you what exactly is going on, especially the history, but also diseases tend to follow certain ages, and always remember that history is pretty much going to be telling you the answer if you'll just pay attention to it. I think looking at the x-ray, the things that do help us when we don't have all that experience is symmetry. Always try to compare the right side versus the left side, and especially change over time. So we're comparing the present exam to previous exam. So symmetry and change are two big things that will help us out. What are we going to need to know about interpreting an x-ray? Well, we need to know some of the limitations that can occur, have to do with ventilation, exposure, and position. We're going to identify some of the normal structures, and we're going to work on a search pattern. And depending on how you want to do it, it really doesn't matter, but just think of all these tissues. Some people like to start from the outside and come in, bones and soft tissues, pleura, fissures, the lungs and airways, and coming into the vessels and the hyla, the heart and mediastinum. But always remember those tubes and support devices, because we put those in and those can make people worse. So I always try to think about those first. But depending on whether you want to start from the outside and go in, or the inside, the heart, and go out, it really doesn't matter. But try to get a search pattern and concentrate on doing the same thing each time. So I kind of like to look at the heart first. I'm in a cardiac hospital most of the time, but we'll talk about more cardiac radiology next time. But again, heart's there in the middle, and we need to know about the heart size and whether it's enlarged or not. We'll talk again about that, but we call that the cardiothoracic ratio, how big the heart is relative to the chest. And with heart failure, we'll see some of that congestion and edema in the lung fields. But thinking more along just from the chest standpoint, exclusive of heart disease, if we look at the airways, we always know we've got that trachea right there in the middle, and we can see it outlined on the lateral, and that's especially important when we have our patients that we've put in these endotracheal tubes, because we want to be able to be certain we know where the tip of that endotracheal tube is, because what happens if it goes down too far, like our friend here, this is extending into the right main stem bronchus, so all that air is being ventilated into the right lung, and the left lung is getting no air, so it becomes completely atelectatic. So that position of that endotracheal tube is key. Central catheters, we put in a lot of those these days, so this little graph here is, or diagram here, is showing you the outline of where those vascular structures are that lead into the superior vena cava, and this x-ray right here is also showing you similarly where all those catheters are traveling. That's that central catheter extending there into the right atrium and tracking with the pulmonary artery. And what about our friend here? Well, this catheter is extending transversely across the mediastinum, and so that's actually going into the left brachiocephalic vein. But understanding that anatomy and where those vessels are can help you figure that out. It's really not that difficult. Well, what else do we do? Well, we put down NG tubes, nasogastric tubes, or orogastric tubes, extend superiorly and want to go into the stomach. So if we follow that, sometimes we can be very surprised when we follow that NG tube and realize that really didn't go into the stomach, that went into the right lower lobe. So that's certainly a misplaced position there, but with all these other tubes and wires on the chest x-ray, it can be very easily overlooked. But just remember, our tubes are what we do to people, and we don't want to make them any worse. How about looking at the lungs, our search pattern? Well, we again want to compare right and left, so we'll compare the upper lobes to the right and left, and we compare the upper and the lower lobes, and again compare it, remembering how that substernal area is good on the lateral to see areas you can't see on the frontal, and that area over the spine on the lateral supplements that region you can't see on the frontal chest x-ray. What do we need to see? Well, if we remember, we've got to find those outlines of those pleura, because that pleura goes all the way there. And so we've got costophrenic angles. We can sometimes see the fissure, the minor fissure, and sometimes we can see the major fissures. And we know that outline. So if we think about the conscious outline of how the lung is outlined by the pleura there, it might be easier for us to tell something like this area of consolidation right here, because we know that sharp outline right there. It's not too hard for us to figure out that that's actually in the right middle lobe. So that becomes pretty apparent. And how about our friend here? Well, that doesn't look very good. Here's the right hemidiaphragm, and here's the left, and here's some of the stomach and colon up here. So we know there's a paralyzed hemidiaphragm, and that's because we followed those outlines and again compared it right and left. And how about our friend over here? Well, if we look at these two lungs, comparing the right lung and the left lung, a lot more density, and if we realize it, there's a lot of density way out laterally in the pleural space here, and so there's fluid in that pleural space, and if we notice, there's the bullet, so he's been on the receiving end of a gunshot, so we're looking at blood in the pleural space, or a hemothorax, where our friend here, again, that looks asymmetric, but if we look at that same area out there, that's all black, that's all lucent, there's no lung out there, that's air in the pleural space, so here's our pneumothorax, so we're comparing the hemothorax and the pneumothorax, but again, looking at those edges of the pleura along the chest wall, following those lines can help us see that there's actually something asymmetric on the right side compared with the left side. All right, so what else do we do? Well, if we again follow that pleura all the way up into the apices, we can see we've got a symmetric right apex and left apex here, and over here we don't have that. And so we've got some apical lung disease, and knowing what we know about this patient's history and symptomatology and such, that's a pretty typical appearance for tuberculosis, but that would be something we could think about. Thinking about bones and soft tissues, well, we know the ribs are there and we know the vertebral bodies are there, so we always have to be aware of that. If we see rib lesions, we could be looking at a fracture or a metastatic lesion in a rib, so we might see something like this if we saw these fractured ribs out here, and we can see that maybe there's a little bit of pleural fluid, maybe a little blood in that hemithorax there. So looking at those ribs is important, because what could those ribs do? Well, those ribs, of course, could puncture the lung, and here we've got a very large pneumothorax here. Again, we can see there's some asymmetry in the left lung here compared with the right lung, a lot more lucency or decreased density, and there are no lung markings out there. So again, that visualization and comparison of the lung tissue along the inner aspect of the chest wall, along that pleura, should help us be able to see that difference between the two. Looking at the vertebral bodies, those stack up nicely. So if we look on this normal lateral, we'll see them all stacked up there. And here's a magnified view. But we can see down here, we're right around the T12 vertebral body. There's a compressed fracture right there, pretty typical for an osteoporotic compression fracture. But again, looking at that lateral and trying to assess the ribs down there and following that costophrenic angle, that's pretty key. How about the mediastinum and the hyla? Always a troubling area to kind of look at. You just kind of have to get some experience, but again, be aware of what you want to look at. Those paratracheal tissues and around that aortic arch, the pulmonary arteries in the hyla and the esophagus we really can't see, but we can see if things are causing mass effects in that region. So how about normal paratracheal tissues? Really not a lot of tissue up there above the aortic arch, maybe a little more on the left than the right. Well, compared with our friend here, large area of soft tissue density, soft tissue mass effect, and we've done our CT scan, so we've got a thyroid mass in there. But again, following that normal expected contours up there, we'd pick up on that mass up there. Knowing that the aorta lives right there, we should be able to see that this looks distinctly abnormal compared with more of our normal here, right here, normal aortic arch are outlined right there. And so what are we looking at right there? Well, we're looking at a big thoracic aneurysm. Here it is on the CT scan. We're seeing the thoracic aneurysm with the iodine centrally and the clot laterally. And again, on that sagittal view, show a large thoracic aneurysm. Thinking again about that hyla, we know those pulmonary arteries and veins are in there. Here we're seeing it on a pulmonary arteriogram and in a corresponding MR angiogram. We know all those vessels are converging and leaving the hyla. It can be kind of confusing, But if we think about our normal x-ray here and compare it over here, we could see there just looks like to be more density, more size, more convexity in the hilar regions bilaterally. So what lives there? Well, we know vessels live there, so could it be enlarged vessels? Well, I guess it could be. They look a little rounded right there. But if we do the scan right there, we can see there's some enlarged lymph nodes right there. So symmetric lymph nodes, we could worry about things like sarcoid, as in this case. Lymphoma would be another one that could occur, something like that. So we have to consider things that make lymph nodes enlarged, especially when we're dealing with something symmetrically. And how about unilaterally? We've got increased density unilaterally here, so it'd be pretty atypical for just unilateral sarcoid, but from the CT scan we can see there's actually a mass there, so we're looking at a lung cancer that's right there in that left hilum, in that aortic pulmonary window, and it could be involving that recurrent laryngeal nerve right there, giving us some hoarseness. But again, that asymmetry of the left hila compared with the right hila, we should be able to pick that up. Again, comparing symmetry. Well, what else might we see? Well, we really can't see the esophagus. We know if we give a patient something to drink, we can see it outlined right there. We know that aortic arch lives right there. We know that aortic arch actually gives a little bit of impression on the esophagus right there. So our friend here, this young child, decided to see if he could eat a quarter. Well, it got stuck. Well, why did it get stuck? Well, it got stuck right there because that's where the esophagus and the aorta are right side by side, and that aortic impression can cause a little bit of relative obstruction right there, and that was where the coin got stuck. Well, what else happens? Maybe older patients less likely to ingest a quarter, but with all the laxity of soft tissues, they can get something called a hiatal hernia, and portions of the stomach can extend into the chest with increased abdominal pressure, and so we might see something that looks like a mass on a chest x-ray, and really it's just a big hiatal hernia. Here we can see it outlined on our barium study with that hiatal hernia outlined. So that kind of gives our summary of our survey, our search pattern that we want to look at. Again, if we just start going from bones and soft tissues and travel all the way in or all the way out, don't forget our tubes and support devices there. We always want to know about that. We've looked over the normal studies and thought about some of those limitations that can occur. And just remember, normal anatomy is really what we're trying to separate here. That's going to come with experience, but that disease will follow the age. Always be aware of who the patient is who's talking, and especially that history. That'll tell you the story. Symmetry and change over time are pretty key. And so I'll leave you with this as just an unknown here. We've put in this catheter here, a right jugular catheter. It's entering from above, and we can follow that right down there. And so there is venous return when we unscrew the catheter and we get venous blood back. So the question is, where is the tip of that catheter? I'll just leave that as an unknown for you, and that ends that. Thank you.